Morning, everyone. I think we'll go ahead and get started. So welcome to the workshop, Your Mouth and Chronic Graft-versus-Host Disease. My name is Karen Brothers. I'm a naturopathic doctor at Cancer Treatment Centers of America in Philadelphia, and I'll be your moderator today. It is my pleasure to introduce you to Dr. Nathaniel Treaster. Dr. Treaster is the assistant professor of oral medicine at Harvard School of Dental Medicine and maintains a practice at Brigham and Women's Hospital. He specializes in oral mucosal and salivary gland diseases and oral complications in cancer patients. Dr. Treaster has published extensively on the topic of chronic graft-versus-host disease and has spoken at numerous professional and patient conferences on the topic. Please join me in welcoming Dr. Treaster.
Thank you very much. That's on. Perfect. And everyone can hear, I hope? Good. I'll do my best to speak up. I know we're competing with sound a little bit here, and I've already had a lot of great questions this morning and during the last break. So, just like the last speaker, well, I'll try and keep my talk to about 30 minutes, and then we'll have about a half hour for questions. Happy to answer questions afterwards. Always happy to answer questions that maybe you thought of, days later as well. So I'm happy to, give out an email address. I don't have cards for everyone, but I don't remember if I have it at the end or I can write it down for people. Thank you again. I love this opportunity. I've spoken to this conference a few times now, and I know, especially from, the first time, it was kind of eye-opening to realize sort of the differences in what type of specialty care is available at different centers, even within, one city, let alone around the country. And as I was talking about during the break, unfortunately, the field that I'm a specialist in, which is called oral medicine, we're actually fairly few and far between. We're trying to make that change, throughout the country, and not just because of transplant and GVHD, but for sort of all sorts of other different oral diseases. So, as you just heard, I'm at Brigham and Women's Hospital and Dana-Farber Cancer Institute. I know that there's some people actually at this meeting who had their care up there, but it's actually a great place, and we work really well together. We work on together on the inpatient side, and then I do again a lot of work with patients after transplant, in particular having to do with graft-versus-host disease. So hopefully I'm not sure if maybe the lights can be brought down just a tiny bit. If anyone has control over the lights. But there's going to be a number of clinical pictures here, and I think it just might be helpful, hopefully, if you find them interesting, just so I can point out some of these features. But, this is what I would consider a fairly severe case of oral chronic graft-versus-host disease. But just to point out, when we're talking about graft-versus-host disease in the mouth, it's really not so different in ways of what we just heard about with graft-versus-host disease in the skin. It's sort of like a rash affecting, the inside of the mouth. And what you see is, normally this would just look sort of smooth and pink, varying shades of pink depending on who you are. But what you can see here is that there's a lot of redness. There's all these white changes, and these white changes are these same lichen planus changes that you heard about earlier for those of you that were in the room. But it just sort of looks different when it's on the mucosa versus when it's on the skin. But under a microscope, it actually looks exactly the same, especially the pathology aspect of it. And then all of this here, where it looks sort of yellow, this is actually where it's broken down and ulcerated. And in most cases, we attribute sort of the worst symptoms with ulcers. But with that being said, we'll see patients that have a mouth like this, and they may be minimally complaining and saying that they can pretty much, eat what they want. And I'll have patients who have changes that are just limited to these white changes, but very extensive throughout the mouth. And in some cases, it can be, incredibly debilitating. So I never sort of judge a patient based on what I see. It's really based on what they're telling me, assuming that there's some correlation between what I hear and what I see. So again, similar to what we heard about earlier, oral graft-versus-host disease is really, really common. The numbers, again, when you look at the literature, just like we heard about with skin, it's going to vary, but you have just about the same degree of involvement with the mouth as you do with the skin. Oftentimes, the mouth can be the first area of involvement. Just like the skin can be the first area of involvement, oftentimes it's the last area of involvement as well. So I see a lot of patients who, have gotten off of all their systemic immunosuppressive therapy, and we're just continuing to manage the mouth, and there's really nothing else that's a problem. Or I have other patients where, they've been put on, high doses of prednisone, for instance, and the skin has cleared up. Other aspects have gotten under better control, yet the mouth still continues to be sort of persistent. So, very prominent site, we talked about this. There's actually a really wide range of symptoms. And I'm going to show you, in I think the next slide or the slide after, that for the most part we're generally thinking about this sort of rash-like change inside the mouth, but there's actually several other important features with graft-versus-host disease that we'll talk about, including in particular the sort of the dry mouth symptoms and some of the really significant complications that can arise from that, other than just being uncomfortable and having to drink water all the time. And unfortunately, last but not least, like we heard about with skin, mouth cancer is also something that patients after undergoing an allo transplant, and in particular with a history of graft-versus-host disease in the mouth, unfortunately are at very high risk. And unlike the skin, where we can use sunscreen and sun protection, which we know is at least a significant risk factor, we don't have that type of risk factor in the mouth. So, oral chronic graft-versus-host disease, and this is really not different from graft-versus-host disease in other parts of the body. There's nothing about one individual aspect of GVHD that sort of is diagnostic or distinctive. And it actually resembles, in many ways, a number of other sort of immune-mediated or autoimmune conditions that I see or dermatologists would see on a regular basis. And so in the mouth, we actually have sort of a combination of the mucosal change, which is this lichen planus-like condition. And I actually see patients with lichen planus in the mouth on a regular basis, and our approach to treatment is really not so different. Although the medical side of things is usually a little bit more simple in somebody with just garden variety lichen planus. There's a condition called Sjogren's syndrome. Some of you may have heard of, and sometimes even just the eye changes are referred to that with graft-versus-host disease. But this is an autoimmune condition that can sort of attack the salivary glands, the lacrimal glands, and cause things to get very dry. And from a clinical standpoint, it's essentially the same condition that we see. And then the sclerodermatous component, this is sort of the deep wood, sort of hidebound changes that we heard about earlier with the skin, fortunately does not affect the mouth and the oral cavity very often, but it can, and when it does, it can actually be very problematic. It can affect sort of from the outside, usually is the most common, where the skin just around the mouth is involved and it just can't open and stretch. But also sometimes we get scarring inside the mouth, and we'll talk about that just towards the end. And it can be really uncomfortable and cause other sorts of secondary complications with the gums and the teeth. Treatment there's a really important role for providing what we call ancillary or sort of topical directed treatment. Like I said, oftentimes even on really high doses of prednisone, the mouth will not completely clear. Sometimes it barely even improves, in which case we really need to treat it aggressively topically. So here are a few very sort of typical examples. And important to keep in mind that the lips are actually very frequently involved with chronic graft-versus-host disease in the mouth. So if somebody has chronic graft-versus-host disease just of the skin and not involving the mouth, they could have involvement everywhere, including the nails, but it's actually really rare that it ends up affecting the lips. It's when it's inside the mouth that it also tends to affect the lips. And so those same changes that I showed you inside the mouth, it's a little more subtle, but you can see here, it's got that same sort of almost like spider web, lacy-like a pattern. Oftentimes, patients and even doctors will think it's just dry. The skin's dry, it's kind of chapped. And just applying something like chapstick, even only Vaseline, it's just going to kind of mask the condition, but it won't actually help at all. And in cases like the one to the right here, where you actually have really much more significant involvement, it's breaking down, there's ulcers, it's cracks, it bleeds. It really needs a directed sort of medical therapy, and I'll talk about in just a minute. Again, just to show you a range, you can see the range here where it's just the white changes. whereas here you actually have this sort of extensive areas of ulcers. And again, I wouldn't look at one or the other and say, this patient absolutely needs to be treated this way and this patient absolutely needs to be treated that way. I usually, ask very simple questions like, how much trouble are you having eating? What type of pain score numbers would you give me? What's worked, what hasn't worked, and sort of direct the treatment based on that. Inside the mouth, again, similar with a wide range of changes, sometimes looking, fairly subtle. Sometimes, we see changes that don't look sort of as classic. They'll almost have these sort of plaque-like changes. But again, there's really a wide variety of how the graft-versus-host disease can look in the mouth. It's important, though, thinking about the fact that there's such a wide range of clinical presentations, because we were actually talking about this earlier during the break. It can actually be very difficult sometimes, talking about cancer risk, to detect the changes that are actually either sort of precancerous or cancerous compared with the wide range of just graft-versus-host disease changes. And we'll talk about that right at the end. This is you have this in your handouts. So I'm not going to go through every single bullet point, but this is just to point out that in some ways we really are talking about three different conditions when we talk about oral graft-versus-host disease. Most of you in this room and most people in general, including physicians, are probably thinking mostly about this component. And it's probably the most common. The symptoms associated are the most frequent and the most troubling symptom tends to be what we call sensitivity, which we distinguish from just pain, because you can have a mouth that looks like this and at rest sitting in this room, you actually may have no pain at all. But you go and try and eat, anything, even just something like a cookie with a little bit of crust or sugar on the edge, and it would feel like, like a razor cutting against the inside of the mouth. With the one of the other interesting features, and I'll show you a picture of this, is something called superficial mucoceles. And these are basically little bubbles of spit that form inside the mouth. They don't tend to be painful. They tend to be more of an annoyance than anything. Of all my patients, maybe 1% sort of fall into this funny category where they're actually somewhat debilitating. They tend to arise with meals. They go away sometimes even within hours, if not by the next day. Sometimes if they persist, patients can kind of pop them with their tongue or their finger, but they're just filled with saliva, and it has to do with you've got minor salivary glands. So you've got major salivary glands that produce the majority of the saliva in the mouth. You've got little ones actually all throughout the mouth, and in particular on the roof of the mouth, and that's where these tend to pop up. The salivary gland disease is really more of sort of the silent, invisible component of oral graft-versus-host disease, because you don't necessarily see any changes, and oftentimes even the clinical exam, when we look in the mouth, it seems like there's a good amount of saliva, it seems to be flowing, but the patient will say, it's really dry, things don't taste right, when I'm eating, the food's getting stuck everywhere, I'm having trouble, swallowing, and it's because the saliva changes. So sometimes it is that there's just actually a lot less, but we actually know just sort of qualitatively there's a change in the composition. And so, unfortunately, the main complication associated with this is that it puts patients at a really high risk for developing cavities. And so we'll talk about that separately in just a minute, and sort of what to look for and what we can do for prevention and management. And then the last being the sclerotic GVHD. And again, the primary symptom is going to be that it's tight and it's difficult to open. You're going to eat something that normally wasn't a problem, and now things don't really fit well. There can be pain, and very rarely I've had patients like you can see in this picture, where the sclerosis is sort of so deep and intensive that it actually causes sort of spasms in the muscle and to some extent a chronic pain condition. Fortunately, very, very rare, but something to be aware of. So these are examples of the superficial mucoceles. Oftentimes, these are thought to be of some sort of viral infection. Patients are, put on different medications or tested. But again, these will come and go. They can actually develop anywhere in the mouth. They can develop inside the lips, on the cheeks, on the tongue. Most common areas on the palate, hard and soft palate. And, these can arise in the context of the mucosal changes, like you see here. but they can also arise with the complete absence. So we don't really understand these all that well, but again, generally more of a nuisance than anything. So I'm not going to talk about systemic management at all in this talk, just because I'm not typically the one that's making that decision. But there's no question that I will have patients where at the time of my consultation, part of my recommendation, and I will, page or email my transplant physician colleague who's referred the patient and say, I think in addition to what I'm doing, we do need to bump up, for instance, the steroid dose, at least for a short period, or maybe start with some steroids. We'll see if we can get the patient off quickly, but we'll start with topical therapy also at the same time, so we sort of have that bridge therapy as we cut back on the steroids. I know there were questions about ECP, the extracorporeal photopheresis. It can work well for mouth disease. In particular, when you look at the literature and, like some of the other studies that Dr. Mayer was talking about earlier, we don't necessarily have great sort of evidence, high-level evidence to support one treatment over the other. But when you look at data that comes from a really, highly regarded center, and they publish a series of 20, 30, 40 patients, and we know that they're reporting good, accurate clinical information, the mouth actually seems to be one of the more responsive organs. So it's definitely something that we think about as a treatment. But just like we were talking about earlier, it's a long, involved path, and it's obviously a lot easier to be taking a pill. But now focusing back on sort of my approach to management. So we'll talk about the mucosal disease first. Just like with the skin, high potency topical steroids are the first line therapy, and we use primarily gels and solutions in the mouth. So the mouth, no matter how dry it is, it's still a wet mucosal environment, and gels tend to be absorbed the best when we're trying to treat a localized area, and solutions work very well because you can rinse around and basically get the medicine everywhere. Even with gargling, you can get it up under the soft palate back to the uvula. This is a fairly short list of medications that we use, and we tend to go with sort of the heaviest hitting topical steroids with the greatest potency. One of the really nice things about the inside of the mouth is it doesn't have the same problem with the thinning and weakening of the tissue with long-term topical steroid use that we get with the skin. The lips are a slightly different area. It's almost like a very, very sensitive, unique, thin area of skin. And so that is an area where we pretty much at all costs try to avoid using steroids. So clobetasol and fluocinolone are the two that we use the most frequently. They're available in gel form. You can get them anywhere throughout the country. And they can work well for treating sort of localized areas. As far as solutions go, dexamethasone is our pretty much go-to standard first-line rinse. It's a very highly potent steroid. It's not actually formulated for topical use. We have almost no medicines in oral medicine that we have specific either formulations or FDA approval for. But dexamethasone works very well, generally well tolerated. We always prescribe it as a solution. And it's something worth mentioning if you have it. Solution versus the elixir. The elixir has alcohol in it. The solution does not have alcohol. Solution will still burn some patients, but the elixir is much more likely to burn. After dexamethasone, so if I have a patient, I usually want to give at least 3 to 4 weeks of really intensive treatment. So 3 to 4 times a day, 5 minutes in the mouth, swishing, spitting, and then reevaluating at that point to see how they're doing. If we haven't really had an adequate response, then I'll usually go to sort of our next level topical steroid. And this is basically the most potent that we have is clobetasol. It's not available commercially in a solution form, so we have to have a compounding pharmacy actually create the solution. We have a pharmacy that we use extensively in the Boston area, but there's compound pharmacies all over the country. And it should be something that can be formulated. Sometimes requires prior authorization, or I oftentimes have to write a note, a letter to the insurance company, explaining the situation, what's been used, why we need to sort of escalate to this treatment. Topical tacrolimus or protopic we heard about again earlier with treating the skin. This is really our go-to treatment for treating the lips, and it's available in 2 different concentrations. And I know when treating the skin, sometimes the lower concentration will be used. We generally will always go with the higher concentration. My approach is, if I can treat as minimally as possible, even if just once a day or once every other day works, it works well for the patient. We've never seen any complications from using the protopic on the lips. We also have tacrolimus compounded into an oral solution, and we'll use that as a combination type treatment. And so we actually published retrospectively a series of patients where we had treated with dexamethasone, and they sort of either didn't respond or sort of stalled out and still really had quite active disease. And we added topical tacrolimus to that regimen. So patients are actually, you have 2 different bottles, but combining the 2, putting both in the mouth at the same time, just like pills would be taken, together in the same day, rinsing together and spitting out. And we've had some pretty good responses with that. I'd still typically go with clobetasol first, and then I'll add tacrolimus as a secondary treatment there. As far as experimental approaches, there's not a whole lot going on in the world of oral graft-versus-host disease. We're actually trying to do a lot of work now just to get a good evidence base. So, for instance, there's been publications recently looking at clobetasol versus dexamethasone out of Brazil, demonstrating that clobetasol, is more effective. I don't think that it makes much sense in most cases to start right up front with that treatment, unless I have a patient where they just come in and they've got some of the worst disease that that I've seen, in which case it doesn't make, we just jump right up. But with that being said, we're doing a study at our center looking at a novel topical agent. So we're trying to see what other treatments may not be effective. Children's toothpaste, when toothpaste causes burning in the mouth, is a really easy fix. It's inexpensive. You just want to avoid anything that has mint in it. And so this is sort of, an example of treating a patient, and you can see that, we really can see significant response with much less of the inflammation, the whiteness. And sometimes in this case, patients will actually notice that they can open the mouth better because the tissue is so thick just from the graft-versus-host disease that it's not as stretchy. One of the main complications of topical steroid therapy is developing a secondary yeast infection in the mouth. Tends to be a fairly, it's not an infection that tends to become more serious than just in the mouth, but it can be very uncomfortable. And oftentimes it sort of masks whether or not the treatment itself is actually working. And I've had patients come back and say, I'm no better, and they actually just have a mouthful of yeast, and the GVHD is almost completely gone. So it's something that we counsel about. In some cases, we have patients who are already on an antifungal medication. And in other cases, we'll just monitor carefully and then treat if necessary. So, the yeast infection, really the primary factor driving it is the topical steroid use. Underlying immunosuppression certainly puts patients at increased risk as well. Unfortunately, dry mouth also puts patients at risk because the saliva has antifungal activity. And if somebody wears dentures, that also can be a really significant risk factor. So we have to talk about, how to disinfect the dentures in a very specific way. Antifungal therapy, we usually use systemic fluconazole, or if somebody's already on if somebody's on voriconazole, that should be, that's going to be sufficient in preventing. Very rarely we have patients who, fail, certain therapy, or actually we do a culture and it demonstrates resistance, in which case we have to use, a very specific antifungal agent. The other complication is herpes reactivation. And so it's, most patients by the time, especially on the adult side, if they've undergone transplant, are put on acyclovir prophylaxis for some period of time because they're what's called seropositive. They've been exposed to the virus at some point, even if they don't have a history of getting cold sores. And that infection can, what we call, sort of break through even while taking acyclovir, 400 milligrams 3 times a day, just because of the stress of the overall condition, immunosuppression. And so, and we treat just by increasing the dose, or if somebody's on acyclovir, we go to a valacyclovir dose for a few weeks, and then usually we can go back to acyclovir. Maybe we go up to a higher prophylaxis dose. And with herpes reactivation, it tends to be very, very painful and very focal, but it can be really difficult sometimes to distinguish if there's really active oral graft-versus-host disease with ulcers, because it can look somewhat similar. And it's something that we at least always have to be thinking about. We generally do a culture to make the diagnosis. In some cases, we'll actually just increase the antiviral dose if we think that's what's going on, and look for resolution. So salivary gland, we talked about a little bit already. Most of us take saliva for granted, but it does a lot that we don't really think about. We think saliva, oh, gross, but it actually plays a really, really important role, not just in eating, swallowing, but also it has antimicrobial activity, so sort of maintains a balance in the mouth. And really importantly, it protects and sort of bathes the teeth. And so when we have less or not as well functioning saliva, the teeth oftentimes become at higher and higher risk for breakdown and cavities. And these cavities tend to develop in very specific areas. So along the gum line, we call the cervical component of the teeth, and interproximally or between the teeth. And these are areas where food tends to, debris, plaque tends to sort of stay around longer. So even with rinsing with water, even with brushing the teeth, these are areas that sometimes don't necessarily get as much attention. In between the teeth, except for dental floss, there's no way to remove that plaque. And so this is, a couple of examples, and unfortunately, sometimes these patients are at a fairly advanced stage before they actually get referred to see me and be treated in our clinic. But what we look for early on are these just sort of very early, what we call demineralizing changes. You can actually see this sort of frosty change, which subsequently can break down. Here in this case, this is what cavities look like along the gum margin. They have this sort of yellow, brownish appearance. This case, quite obvious, sometimes can be a little bit more subtle, like in the upper images. And it's not really common for this to develop at a rapid pace, but in some cases, we can actually see these changes occur, in the matter of months and not, over years and years. And this is an example, we see all of our patients before transplant. I'm not expecting you to understand how to look at dental x-rays, but I'll tell you that in the upper, you essentially have almost perfect teeth, very minimally restored, a few fillings, patient in their 40s or 50s, and within just over a year after transplant. And unfortunately, this is the first time the patient actually ended up getting referred into our clinic because of other complications they were having. Essentially all the teeth are completely broken down, and you can see when we look at the x-rays, that's all decay, where the tooth structure is actually just missing. So for symptoms, there are over-the-counter dry mouth therapies. I don't necessarily favor one over the other, and there's always new ones coming out. So I think experimenting is always a good idea. Sugar-free gum can work very well in just stimulating salivary flow as long as the glands are functioning to some extent. And then we actually have prescription, what we call sialagogue therapy. So there's a couple of medications. And I've got these summary slides at the end that I'm not going to go through in detail, but you have them as a resource. But two medications, one's called pilocarpine, the other one's called cevimeline. They're essentially identical medications, and they, in some patients, probably about maybe just under 50% of patients that we'll actually go ahead and treat will have some response. They actually just stimulate the glands. They're not immunosuppressive at all. Taking good care of the teeth is really important. It's a hassle, and sometimes there's debilitation, and if patients don't have good range of motion, it can become difficult. So finding a good regimen, if it requires using an electric toothbrush versus a manual toothbrush, good brushing at least twice a day, but ideally after meals as often as possible, flossing on a regular basis, and when we know somebody's at risk, at least from clinical findings or just based on sort of the overall clinical situation, we'll actually, preemptively start prevention with topical fluoride, which can be used in a gel form. Sometimes we just paint it on with a toothbrush. Sometimes we use trays We can also apply fluoride varnish. It's really a high concentration fluoride that's applied directly onto the teeth. And there are these sort of new area of interest with these remineralizing agents, which work sort of together with fluoride to actually help sort of build the mineral component back up in the teeth because the saliva isn't doing what it's normally doing. Seeing a dentist regularly is critical. If there's cavities, they need to be treated because they'll progress over time. And these patients also, with the salivary gland involvement, are going to be at risk for the recurrent candidiasis. And I know we're almost out of time for the talking part of this or the presenting part, but just to finish on, unfortunately not a high note, but one of the things that we actually really need to educate patients, doctors, dentists about, because being aware is really important to be able to detect cancers. And so, unfortunately, the risk of what are called solid tumors, and mouth cancer is considered a solid cancer, doesn't really start until a few years after transplant. But the better you do and the longer you live, the greater your risk is over time for one of these cancers developing. And unfortunately, skin and mouth are the two most common sites, probably in large part because of the component of graft-versus-host disease sort of driving cancer changes. And this is a slide just showing that it can look very different. So it's always squamous cell carcinoma. We don't have basal cell carcinoma or melanoma in the mouth, but it can look very, very different from one patient to the next. So here there's just this, sort of odd, sort of pebbly red and white growth. Here we have what looks like just a little sort of white patch. Here there's sort of this heaped up mass with a central area of ulceration. And then here you just have this very well-defined solitary ulcer. All of these are examples of squamous cell carcinoma. So in summary, involvement in the mouth is very common, maybe the initial site, maybe the last site, very wide range of sort of signs and symptoms and sort of all these various sort of components of how the mouth can be affected. We have some, very good, effective, fairly straightforward approaches to managing the mouth. It's an easy area to treat. It's sort of this enclosed vessel. So, using the solutions works very well. Avoiding irritating types of foods and drinks. I didn't go into a whole lot of detail. It's usually very obvious, but acidic foods, spicy foods, foods with just very strong flavor, mint flavor, rough textured foods, tend to be very irritating with the mucosal disease. Managing the salivary gland changes, preventing cavities. Seeing the dentist regularly is really, really important. I don't know that it's critical to go any more than the standard twice a year and have cleanings and x-rays. But some patients, especially those we know are high risk, we will get x-rays every year, not every 2, 3, 4, 5 years. In some cases, even every 6 months when there's really, areas that have been active with cavities. Oral cancer surveillance, patients need to be aware. You need to, understand if something seems different from what you've been used to, but also making sure that, the transplant physician should be looking in the mouth, nurse should be looking in the mouth, dentist obviously looks in the mouth, and, it may require treatment for years. And sometimes, like I said, even when you're off of systemic immunosuppression, this may be something that requires treatment locally for months, if not years, and sometimes it'll come back at certain times, requires treatment again. So I'm going to stop with that. I just want to go over what these slides are. I'm not going to go through them in detail. This is a summary slide I put together, just talking about sort of the most common prescriptions that we use for treating oral graft-versus-host disease. Most of your physicians should be aware, but some are more familiar with others and not others, so this is a nice resource. This is a table from a publication we had a year or two ago, just going through various guidelines for sort of screening and prevention, management of late complications having to do with oral graft-versus-host disease. And I'll stop there and answer questions. So thank you very much.
Thank you, Dr. Treaster.
Thanks.
We'll take questions now.
And we can bring the lights back up.
We'll take questions now. Just ask that you raise your hand so that the mic can be brought to you, so that everyone, even those who are unable to attend, can hear your question and the answer on the recording. Okay?
If you don't mind also telling me where you're from, I always find that really interesting. So.
I just had a question. I just wanted to, I'm from Baltimore, Maryland.
Okay.
Is there any way you can just pull up the last slide so I can write some of it down? Because it's so small in this
really?
paper that I can't read it.
Sure. I'll just leave it up. This one?
You. Yes.
And then if you want to bring another one up at some point, just tell me. Say, go back another slide.
Okay, thank you.
Yeah. There was another question in the front, right?
I had my transplant at the University of Pennsylvania.
Okay.
And I live in Pennsylvania. And I'm about 3.5 years out. I have had mouth issues pretty much from the beginning and have done the dexamethasone. I still do that. Swish. I do I have a tray for the clobetasol. Done the compound of the tacrolimus. And while it keeps it in a certain level of maintenance, I still have a mouth ulcer that just doesn't seem to want to go away. But it's not horrible right now.
Good.
But my question, I guess, is does it ever flame out and stop?
Short answer is yes. I mean, it eventually does go away for most patients. But with that being said, it can persist at a fairly low level for years. I mean, I do see some patients that are 6, 8, 10 years out, and there's still active oral graft-versus-host disease. Now, if you were transplanted for malignancy, like most adults are, we tend to think that's actually a really good sign, because as long as there's some evidence that there's been long-term ongoing graft-versus-host disease, it means there's also this long-term ongoing graft-versus-lymphoma or leukemia effect. So, and sometimes also, once it goes away, it kind of leaves just funny changes left behind. So, like sort of funny white plaques in particular, that we don't really know what it means, but they oftentimes don't really change over time. So I don't necessarily biopsy that over and over again, because, if it's stable, it's not cancer.
And I have one other question.
Yeah.
As far as the salivary, I actually drool as opposed to having dry. Is that something that you...
I hear it occasionally, but it's not a really common, not common, but I just say that's probably a good thing. Now, I assume you're being seen by oral medicine
Yes.
at UPenn?
Yes.
Good. So I was saying we're few and far between, but it's one of the probably strongest centers in the country. Do you mind me asking who you see?
Well, right now I see Dr. Stupor.
Excellent.
And I have my teeth cleaned every 3 months by Dr. Endy.
Okay, good, yeah.
At home,
But
so.
no, Eric Stupler is fantastic. We're very good friends. So.
Oh, good.
He was 1 year ahead of me in dental school, and we both went to Penn for dental school. So.
Well, and I can't remember his last name, I remember his first name, Dr. Andre.
Yeah, Andres Pinto.
Yeah.
Yeah. He's in Cleveland now.
Yeah.
So, yes.
Hi, Doctor. Thanks so much for your talk. I really
Thank you.
appreciate it. It's very good. We're from New Jersey.
Okay.
And I had my transplant a little over 6 months ago. And like you, I have the same issues, dry mouth, and everything tastes awful. And I've always taken really good care of my teeth. And it just so happened I had a dental appointment before the transplant. Everything was great. That's 6 months ago. And now I went back. Every single tooth has decay.
On the
Every
gum line?
single tooth.
Gum line?
Gum line. Yeah, just like you showed. And,
So it may mean that you're sort of in that high risk group, that
Yeah.
I talked about, where things can happen quickly.
yeah.
So, I mean, the things that you need to do are brush after every meal.
I do.
I know it's a hassle.
Yeah.
Fluoride nightly, and probably ideally with trays. So she was talking about clobetasol and trays, but we can use trays for the teeth or to get over the gums.
Right.
Possibly the use of the remineralizing agents. I mentioned, and it's there's sometimes dietary considerations as well. So you want to be drinking, for just like drinking water as much as possible, rather than even juice has sugar in it and kind of like feeds the cavities.
Right.
But it's really just oral hygiene, the prevention, and getting in regularly. Make sure that they take the bite wing X-rays.
They already did.
Yeah.
In fact, my dentist,
once you start seeing the changes along the gum line, it's not always a guarantee, but very likely that there's changes going on in between the teeth as well.
Right, right. And my dentist said it's going to take like a year to fix. But after that, can it be prevented?
Well, I mean, the prevention starts now. It's, you know,
Well, it's already.
So we don't really, I mean, I guess the short answer is we don't really know.
Mm-hmm.
So there's no sort of interventional studies in particular with chronic GVHD patients. I have to believe that at least with the efforts that we put in, and I mean really the patient puts in, that it will at least slow down or attenuate the progression. I mean, otherwise you're just going to give up, right? So that's not good.
Never.
Yeah.
And I'm so sorry, I'm the spouse.
Yes.
So I have to cook for him, so no spicy foods. But they say lemon water somehow alleviates the dry mouth. But that's acid, right?
Yeah, I mean, I would, you know, as long as it's short-term exposure to something acidic in the mouth,
It's
probably
okay.
not the end of the world. But, you know, the idea with that is just to stimulate saliva. And sure, you know, a sugar-free lemon drop can help, but sugar-free gum, I mean, just the activity of the taste and the chewing is generally about as effective.
And I don't know that xylitol is good?
Yeah, I mean, there's a lot of talk about xylitol. I mean, what in particular is good with xylitol is that it seems to actually potentially have sort of an anti-cavity effect. And it's has good flavor. It's a sort of a sugar substitute. Sort of how effective it is sort of being anti-cavity is, I think, not totally clear. But it's certainly not something you should avoid.
So, I'm so sorry, last
Yeah.
one. So the bottom line, having prevented, is it possible to take steps to prevent both oral cancer and the cavities? Or this is
So they're two totally different processes. So the cavities, it all has to do with the saliva. Like the teeth never change.
Right.
Teeth develop, they erupt, and then they're there, and they hopefully last until we're dead. With the mucosa, it's, you know, they're basically like genetic, molecular changes, injuries, however you want to think about it, that are occurring sort of collectively, cumulatively over time. And, you know, we never know sort of what drives the cancer more. Is it immunosuppression because the immune system, you know, has a surveillance role? But we also know that the chronic inflammation can drive cancer. There's many cancers we know that are caused by chronic inflammation. And it can be a really debilitating condition, you know, oral GVHD. So without knowing sort of which side of the balance plays as or more important a role, and maybe they're equal, you know, my approach is treat the oral GVHD as aggressively as necessary to be comfortable, because we don't know that is really increasing risk in any way. And the overall risk of developing cancer is very small. It's just that within this population, it's huge. But for a given individual, the risk is still small. So, yeah, there's a question back here.
Hi, thank you. I'm Christina. I'm from Michigan.
Mm-hmm.
And I was wondering more about this cancer. It just looks like on your graph that it goes up exponentially, kind of the solid tumors.
It doesn't stop, as far as we know.
So do you have a percentage or an incidence as far as, like, you know, how many people get oral cancer? I'm confused. Like, is it if you have oral GVHD and you continue to have it, does it go up exponentially? Or if you...
So it's the problem is there's very, very little data specifically about the patients with mouth cancer. It's basically epidemiological data, meaning that you use these massive databases and then look at who develops. But we don't actually know anything about those individual patients. So we've done a small study within 3 centers where we looked at the patients that did develop cancer and looked at, you know, all the different aspects, you know, and found that essentially all of them had very significant oral graft-versus-host disease. But there aren't any, like the kind of information you're looking for, it doesn't exist at this point.
It seems kind of nebulous, like how, you know. Okay. And my dentist always...
But the screen, you know, but like as far as education and screening, it should be the same for everybody, whether you have oral GVHD or not. So,
Oh, so is this is specifically your chart here with the, that goes up exponentially. That is for just BMT patients, correct?
Yeah.
Okay.
Yeah.
Okay. The other question I had.
Allo BMT specifically, because some
Yeah.
patients who undergo an auto transplant don't have the same risks at all.
So with the GVHD and having the anti-leukemic effect or whatever, I've heard that it also can have, it can help in preventing other types of cancer, the GVHD, theoretically.
I think that's theoretical,
Okay.
right?
All right. So, okay. And the other question I had is, my dentist always says that what I have looks, he's not treated someone with GVHD before,
Yeah.
but always says I have lichen planus.
Exactly.
Is
So
that the same thing?
I mean, from a clinical standpoint, if you just throw up a picture, you would never be able to distinguish one from the other.
Are the
I mean, I would say
mechanisms
that with
different?
years of experience, there's things that I sort of think of a little bit differently, and the mucoceles are a really unique component. In lichen planus, I would say that 0.01% or something of my patients develop a mucocele at some point, and never a lot of them. Whereas with graft-versus-host disease, it's common.
Okay. Thank you.
And a lot of people will refer to it as lichen planus-like changes, calling oral chronic graft-versus-host disease.
Do you know anyone in Michigan that's
Unfortunately, I just tried to arrange for a consult visit for not a cancer-related oral disease, based on some emails and requests, and there's not really anyone in Michigan right now. It's kind of frustrating.
Yeah.
Yes. In New Jersey, yes. New York City, yes. Philadelphia, yes. So I can.
Thank you, Dr. Treaster.
Yep.
Rick Kilmer, Austin, Texas. Excuse me, a comment mostly. I was unable to attend last year because of a lung GVH issue that nobody would have wanted to be around me. And so I canceled at the last minute. What I found is that they published on site all of the slides, including the pictures. And I ended up getting the pictures off in a printed form and the slides, and took them to several doctors, because the doctors don't understand GVH, but with this they were better at it. And so it was very, very helpful to be able to get that. A comment, though, is you show the more extreme versions of the issues that we face, and that's less likely. It would be nice to have some photos of the less extreme lichen and all the other issues, so that they can see what they're more likely to see.
Yeah.
But thank you for...
Yeah. Well, I had the slide that showed 4 pictures of the cheeks, and the bottom 2 were more severe. I would consider the 2 on the top fairly garden variety. And you just have this kind of, like white rash-like change throughout the mouth.
Right.
One on the tongue where it's just the white, lichenoid changes also.
It seems that the photos from last year, that there were more of the photos and more of those. I may be wrong.
Yeah, I think I may have switched things up a little bit. So.
But thank you.
And another good reference, and not to self-promote, but that table that I had, and a couple of the tables were from a publication we had in Blood, and it's called How We Treat Oral Chronic Graft-versus-Host Disease, co-authored with a few of my medicine colleagues, and again, like I said, I will. Happy to give email address to anybody, and you and/or your doctors can email me. I'm happy to send the PDF version of that article, because if you go into PubMed and try and bring it up, you probably have to pay for it.
Thank you.
Yep. Here we go. Another one back here.
Thank you for everything you've said. I have 2 questions. One is, probably a lot of people experience this loss of taste. And it doesn't seem to be changing. And I asked somebody yesterday at a workshop, and they said it probably won't change. The taste buds go. And you say not to have spicy foods, but that's one thing I can taste.
Yeah. So again, one of my summary slides, wide range of symptoms. Some people will have, they would say, this is the worst aspect of my graft-versus-host disease, is the mouth. Mm-hmm. But then within what the mouth symptoms are, you could be on two different sides of the spectrum. So, and that can, taste can, it can lead to loss of appetite, weight loss, depression, and so, taste can actually be really pretty significant. In some cases, if there's active graft-versus-host disease, treatment of the graft-versus-host disease leads to improvement of taste, but not always. Sometimes if the mouth is just really dry, managing the mouth dryness can help. If it's taste changes that have sort of started since around the time of transplant, from the conditioning or whatever factors we don't even necessarily know, and it's just persisting and persisting, that I don't want to say always, but usually by 6 months to a year, it does improve, not necessarily completely back to normal. And very rarely we have patients who, changes will sort of come on at a later time or sort of in a more atypical way. And we have a few approaches sometimes that we'll try, but it's really, kind of like we heard about earlier with some of the things that Dr. Mayer was talking about where, it's really a one-off, like I've done this in 5 patients or 10 patients. You have to be really careful about, giving that as sort of medical advice.
Okay. And I forgot to say Kathy from Philly.
Oh, very good.
Temple, not Penn.
Okay, they're
Rival.
both great institutions.
And the other thing is, so I've had 2 transplants. I have a lot of graft-versus-host, and actually tomorrow I'm having a tooth extraction.
Mm-hmm.
Just it's a tooth that's had cavities over years and it's gotten worse. So what would you recommend? I talked to the dentist last week. He's a neurosurgeon, and he told me to double my my prednisone today and tomorrow and Tuesday, and he's not going to put me to sleep. He's going to do, and then he talked about putting in an implant, and I don't know if that's a wise thing. If you have,
well, I think so I don't want to get overly involved since you've got obviously a good doctor. That sort of steroid regimen, it's somewhat controversial. Whether I would say that more often than not, we wouldn't, unless you've met me asking what dose of steroid are you on a daily basis?
10.
10?
So.
Probably not necessary. Mm-hmm. And as far as an implant goes, what tooth is it?
Oh, it's in the bottom.
Bottom, and is it all the way in the back or second to back? Not all the way in the back. I think that. This is more of sort of a philosophical question than having to do with you specifically, but in the front, sure, from aesthetics, people don't want to have missing teeth generally. In the back of the mouth, it's really a personal preference. What I generally recommend is, unless they're really pushing to do something immediate, just get the tooth out, see how you do over a few months, and you may find that you could care less if you have a tooth there.
Right. Okay. I meant not my decision on that, but like having an implant.
It should be perfectly safe.
In terms of,
there's always some risk after long-term steroids, without knowing what your underlying diagnosis was, but within the allo transplant sort of adult cohort of patients, most patients with multiple myeloma do not undergo an allogeneic transplant. It's usually auto transplant, but those patients are treated with these bone modifying medications often, whereas most patients with a history of lymphoma or leukemia have not been on these medications. But a lot of females, you may have been on Fosamax, and so that does actually potentially, cause some complications. I still think the best thing is to get the tooth out, and assuming everything heals well, just see how you feel, and you may just say, I just don't really want to deal with anything else in there. Yeah. Any other questions? Yeah.
Actually, a comment just to piggyback off of what she just said. One of the things they're learning now about oral health related to biphosphonates. I had Zometa as an early on treatment. I have multiple myeloma. By the way, I'm Kelly from Connecticut. Sorry.
Okay.
And I actually have osteonecrosis of the jaw.
Yeah.
And they're finding that is much more common than they originally thought. So, just a thought for this woman is I'm thinking like you go through. My husband just had a tooth implant. Like that's a long process and a big investment that insurance doesn't usually cover, and it might not take if there is some involvement of the jaw. I mean, I'm not a physician certainly, and I don't know, and everybody is different, but that's just a thought. And then another question I had is if you could talk a little bit about like how oral GVH is related to GI GVH, because really doesn't your GI tract begin in your mouth?
It does, and it's one of these really interesting aspects of graft-versus-host disease is it will not usually go past the palate. So it does sometimes. It can go into the esophagus, but in most cases, oral GVHD, oftentimes it doesn't even go beyond the hard palate. So we distinguish between hard palate and soft palate mucosa. It's actually rare that it goes, like that one case I showed you where the whole soft palate was really inflamed. It's actually pretty rare. It's usually cheeks, tongue, lips, not in the back. And there's not a great correlation with actually like lower GI and mouth with chronic graft-versus-host disease.
Last question.
Yeah.
Hello, Chris from Queens, New York. Well, to those of you who do not have any taste right now, there is hope. Mine came back in full effect. So.
And how long after transplant?
It was about 2 years, though.
2 years? And was it something where, like, I mean, you noticed the change at the time of transplant, right? It wasn't months after that it developed?
No, I noticed the change.
Right.
And my question, there are times when I get very dry mouth, and the Biotine toothpaste and mouthwash doesn't really get it all the time. Is there anything else you can suggest?
Yeah, you know, there's the Biotine product that I actually recommend the most for patients like you, and especially with nighttime dryness. Have you tried the gel? It's actually like, it looks like a tube of lubricant, but it's for the mouth. Yeah, and that is it's I mean, it's, you know, nothing is magic, but especially for nighttime dryness, you know, where it's like waking you up, exactly. You just squeeze a little bit out, you just put it on the tongue, and it just kind of melts into the mouth. And, you know, you want to drink water, but if you drink water, as you know, within like a minute it feels dry again, and then an hour later you're getting up and going to the bathroom. Right. Right, but then you have the same symptoms and you're getting up and going to the bathroom, and this works really well. All right, that's it for questions? All right, great. Well, I'm happy to answer afterwards. Okay.